The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us, in person or virtually, at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Hey everyone, welcome to another episode of APIC's The 5-Second Rule. Today we're going to be talking about personal protective equipment, and we could go on forever about this topic. And we have two great guests that are going to share their expertise. We've got Darlene Carey, who is a certified infection preventionist, and she is the System Director of Infection Prevention and Control at Northside Hospital, Gwinnett, and Duluth campuses, and I believe that's in the Atlanta area. She's also served as the recent chair of the APIC Practice Guidance Committee, and she also represented APIC at the Centers for Disease Control, HICPAC, that's Health Infection Control Practices Advisory Council, and we are pleased to have her here. Hi, Darlene.
Hi, Silvia.
Darlene, you are being joined by fellow colleague Georgine Kruedelbach, who happens to be the Director of Infection Prevention and Performance Improvement at Naples Community Hospital Healthcare System. And Georgine also was among the emergency trauma Decon team at Lee Health System. And she's got an advanced degree from Nova Southeastern. And I believe you were also part of an African medical mission trip. Is that right, Georgine?
Yes, it was in 2009. Great experience.
Wonderful. Okay, so you're both here to talk all things personal protective equipment, or as our fellow infection preventionists and healthcare workers know, PPE. So I'm going to start with you, Darlene. Give us an overview to all of our listeners about what we're talking about when we're talking about PPE, because we know a lot of folks in the public now are hearing more and more about it, but walk us through what it is that we're actually referring to.
Okay, thank you, Sylvia. So PPE, of course, stands for Personal Protective Equipment. And now in the world of healthcare, we utilize this, we being our healthcare workers, whether it be frontline staff members or anyone that we have direct and sometimes indirect patient care, we utilize personal protective equipment, or PPE, to protect the staff member, the healthcare worker, against any transmission. But at the same time, we can protect the patient as well if there is, maybe one of our healthcare workers is maybe not feeling well. So that serves as a protection mainly for the healthcare worker.
Okay, but what are we exactly talking about? Things like masks?
Yes, so thank you for that reminder. So so that includes, and what we consider this mask, gloves, gowns, eyewear, so any type of protection that we would need to cover, and typically our clothing, any mucosal areas, our eyes, nose, for protection when we are providing care to the patient.
Okay, because obviously, and we'll get into this a little bit more, I think anybody who has ever sadly been in a hospital, or really across the entire continuum of care. So whether you're in the hospital, you go see grandpa or grandma at the long-term care nursing home, or maybe you're just going for an outpatient procedure, we see different layers of this, correct? But break it down for us because, for example, we have masks and we have respirators, right?
Right. Okay, so and we'll just kind of we'll start with the mask, Sylvia. So we can have what's considered a procedural or surgical mask, and so that is utilized if there happens, maybe a spray, a droplet precaution type patient that we would utilize that mask on, and that's very common even in the OR setting. Of course, they're all wearing what we consider surgical or procedural masks. And then, of course, there are respirators, and so that protects the healthcare worker for what we consider airborne risk or airborne particles, and those masks are made to obviously filter and commonly referred to as like N95 mask to have that particular filtration for any of those airborne particles that may be a transmission risk to the healthcare worker.
Okay, yeah. So we're seeing a lot of that now, and those procedural masks are those, little blue looking, sometimes white masks. We have respirators. And oh, by the way, folks, episode 15 of the 5-second rule talks a little bit more about a respirator versus a procedural mask. And then you've got your gowns and your gloves and your face shields and eye protection. So I know that at APIC, among our members, certainly talking to other healthcare workers, one of the biggest, questions that comes up or issues is around compliance with wearing personal protective equipment. And then the other thing is figuring out the best way to put it on and take it off, the whole donning and doffing. So I'm going to turn to you, Georgine, because I think you've done some research in this area around compliance with PPE. Can you talk us through that and help us understand what's going on and why are there challenges around compliance with, putting on the right thing the right way?
Thank you, Sylvia. I think it is a challenge for healthcare workers to apply the PPE. So I think also healthcare workers tend to perceive the risk of not wearing PPE as much less than it truly is. So when we did a 3-year study at my organization and looked at healthcare workers applying PPE correctly and what components they did better at and what components they didn't do so well at. And when we looked at employees and different across all the disciplines, we had about 73 to 89% performance for just putting on the mask, the gown, or the gloves when they had to put on their PPE. But then if we added the entire components of doing hand hygiene before donning the PPE, doing hand hygiene when removing it, and then also using soap and water for those C. diff or norovirus patients after they remove their PPE, we saw the compliance fall to about 38 to 73% compliance.
Okay, so that's a lot of information. So I want to go back.
Yeah.
So there's a couple of things. There's actually, did you put on the right item?
And staff do have challenges with that. And sometimes even in the hospital, we've communicated incorrectly, and maybe we found that we didn't have the appropriate signage on the room. So I think staff really do try to put these items on. And I think what we're seeing is, especially when we looked at the COVID situation or even Ebola training, is that staff did tend to miss hand hygiene. It's one of the most important things you need to do when you're wearing PPE, so you don't contaminate yourself when you're removing it as well. So some challenges with hand hygiene performance, and then PPE fatigue. So what we're seeing with employees, they just want to run into the room, they want to get their duty done, they don't think they're going to be touching the patient, so they skip putting on PPE. So we do see that frequently.
Right. So it's about making sure you read the signage. Hopefully the signage is there, and then the proper putting on and taking off so that you're not contaminating. And by the way, we do have an episode, because you cannot get past an episode of the 5-second rule without talking about hand hygiene, which is so important. Darlene, what are your thoughts on this and compliance? Because you're at a large health system that, you have the hospital and you have outpatient and ambulatory. What are your thoughts on some of the challenges for healthcare workers to comply with this? Because we know everybody wants to do the right thing always.
Right, and I think I appreciate that question, Sylvia. So one thing that I've seen, and across the healthcare continuum, really, some of the challenges is having, the choice of PPE readily available. And of course, you want that at point of care. And so ideally, where the employee needs that PPE or have that selection of PPE, have the selection of the gloves. If the gloves is on the other side of the room, not near the patient, then you've got to cross over. So I think knowing where to place that, so again, that you're increasing compliance, just like hand hygiene, to have it readily available at point of care, obviously is going to increase your compliance. The other part that Georgine mentioned is knowing the selection. Even though we have the signage on the doors, it's understanding that selection so they are in the right kind of compliance. The other thing that I think is important to know is the fit. Now, sometimes depending on the mask, especially the procedural mask, if you have the tie mask or the ones that do around the ear loop, sometimes there's gaps in there. Same thing with eye shields and face shields that, may have some, different openings, or maybe the fit's not there. And I think that's important for staff members to give feedback, and I know an infection preventionist would, be in tune to that when they're doing rounds and as such, that they can see what barriers may exist there for the staff member so they can remove those so we can increase the compliance.
Yeah, I certainly recalled back in the day in my clinical career, the frustration because I have these huge man hands that they were always out of large gloves. Or as you say, you'd get to the ICU, you're outside and, the cart is empty or, you're running around trying to get the right thing. So it really is important, as you say, to ensure that the supply is there. Which brings me to, what we've heard for a long time are issues around ensuring that those supplies are stacked, that they're maintained. Do you find as infection preventionists and patient safety officers, where do you see that that's a challenge? Who does that? And is this an issue of leadership or, teaming and collaboration? Is it environmental services that does it? Is it the nursing staff?
Right. So Sylvia, I think you bring up a really great question, and that is going to depend. I think that is facility dependent and sometimes departmental dependent, as in, is it going to be the patient care tech? Is it going to be the medical assistant? So I think the most important thing is to identify who that person is and to ensure they understand their role and expectation, and that certainly will help out with ensuring that supplies are there. That's part of the end result, but also that communication in understanding the ordering, the PAR levels, et cetera. So I think it's operationally understanding who is in that role, what their expectations are, but also communicating it and ensuring that we have adequate PAR levels.
That's really interesting. Talk to me about the hierarchy of controls and PPE.
Okay, sure, Sylvia. So the PPE, just imagine, if you will, when we have what we call hierarchy of controls, is an inverted triangle, and PPE is at the sharp end of that triangle. And just briefly, I want to mention the other one. So we have elimination, substitution, engineering controls, administrative controls, and then PPE. It is important that all of these other controls prior to PPE are in place, so that PPE really is that front line right before the patient that is in place. And so that it plays an important role, but it is the very end line before the patient. So there's a lot of detail there. And again, all the other controls are incredibly important to be in place, because without all of those, then we might have some challenges if PPE were the only thing, the only control that we had. Georgine, do you have anything to add?
Yeah, I have some examples that I'm thinking about where where we institute that elimination or try to do the substitution and administrative controls. When in the case where we decon, where we try to remove a chemical or hazardous exposure, maybe outside of the hospital in a tent before we bring those patients in to keep the other healthcare workers safe. And then the other thing I'm thinking about is during COVID, how we've installed the screens and the curtains and engineering controls with the airborne infection isolation rooms and the portable HEPA filter units that we space throughout our community, in our ambulatory locations and our hospitals. So I think that the more we learn about transmission of germs and how this happens, we're able to keep our healthcare workers safe, but we still have to use that PPE correctly, and even it is our last resort and last defense against spreading infection. But I think one other thing I wanted to mention was that we really have to protect ourselves before we put hands on patients. So I think we learned that lesson as well with Ebola, is that the risk is there, and we cannot just jump in and start taking care of the patient without those controls and then using our PPE.
Can I ask Georgine, I'm going to ask you too, Darlene, as infection preventionists, how much of your time, I mean, and this is just a conversation, so we won't hold you to it as, gospel, and there's probably some research around this. How much of your time as infection preventionists is spent dealing with PPE compliance and supply issues around there? Ballpark.
Yeah, I think for outside of a pandemic, it's actually pretty small. We do have a lot of support for that, so probably 5%. But during the pandemic, I'm sure we can all attest that we've spent much more time trying to make sure we have supplies, educating on all the different styles of PPE that have come in during the shortages, educating staff on how to select a mask or even a gown when they're doing procedures. So a lot more education is going on right now as well.
How about you, Darlene?
I think it's the same as Georgine, because depending on whether we have any type of influx of infectious disease, so whether that's pandemic, if we see an increase in our influenza season, certainly around, depending on the time of year, whether we see, a MERS coronavirus, a MERS CoV, we've seen that in past years. Also, depending on where your geographic location, and then if you're in a children's hospital as well. I mean, I think, during those, again, those influx, we're going to have a lot of input at that time. Otherwise, I agree. I think it's about 5% of, an average day or monthly time period. But when those influxes happen, she's absolutely right. Then we really have to, be boots on the ground and give a tremendous amount of education and re-education to ensure that the staff remain safe.
Okay, well, that's interesting because if I'm understanding, on a normal day, a pandemic aside or epidemic aside or specific outbreak, is it fair to say that if you're only spending that much time, either, people are knowing what they're supposed to be donning and doffing, but that when something hits that's a new pathogen, are you saying that that's where it ramps up and you're really having to educate people in terms of what is proper? And I ask that because if we look at the SARS-CoV-2, the COVID-19 pandemic, certainly that's a new novel pathogen. And so there is some education for everybody to understand, okay, how is this transmitted? What do we need to wear? But it's interesting, and I'm just having the conversation with you both to understand that, everything's rolling along. And I guess I just wonder why all of a sudden there is this need to re-educate. I'm just curious about that. Is it because the science has to catch up with transmission? Is it managing fear? Is it we don't have enough? I'm just curious what your thoughts are on that.
I can jump in on that. So I think that it's all of the things that you mentioned. So I think what we learned is that the employees' fear, when I look at the study that we did, we had our best compliance in 2015 when we had the threat of Ebola in the United States. So staff awareness really increases. They want to know, they start calling, they have lots of questions. So I definitely think it has to do with the disease. Another thing is when we have an improved testing. So now we've got testing with the respiratory panel that identified a whole bunch of new pathogens, and so we had to educate staff on how to what PPE to wear with each infection that was on that respiratory panel when it came up positive.
Okay. Yeah, no, it's just interesting. Darlene, I'm going to ask you this. I mean, I'm going to take head coverings. That's a pretty controversial topic. Head coverings in the operating room. And I know that your work on the APIC Practice Guidance Committee involved some of this. So can you share with our listeners, who again include other healthcare workers, maybe some surgeons listening, we hope, and the public, share with us a little bit about what you know of that controversy around head coverings, and I think also some questions came up around facial hair and all of that. Can you share a little bit about that?
So, and you know, Sylvia, I think this is really not anything new, as you'd mentioned. We've seen this ever so often. I think it really comes to light a bit more, and through whether it's the APIC or, you know, we've seen items published in AGIC. Also, our surgical colleagues, you know, have done research as well. And so when we think of hair covering in a surgical setting, especially in the OR, you know, we've got, you know, with ARN guidelines, we've got, you know, hair should be covered, and we've got typically what we call the bonnet, and, you know, which is blue, white, you know, there's different colors. I've actually seen red, and I'm sure Georgine has seen a multitude of colors as well. And so is to have that covered, you know, make sure it's covering, you know, anything that, and again, all hair, et cetera. And even that for beard wear, and the whole point is to maintain that sterile field, so nothing, you know, no hair or any debris from the head that would go into the sterile field. Now that is your historical. That's what we've pretty much utilized across all healthcare facilities. And then, you know, there is the question of individuality, and being that, you know, we have the cloth coverings, and I think that for many years has, you know, well, is this okay to wear? Because as the bonnet, as our surgical bonnets, typically those are disposable items. You know, we dispose of those after the case, whereas the cloth hair coverings, you know, sometimes people will utilize those maybe for the week, and we're not sure of when those are laundered. So I think the debate is out there. I know there have been some published, you know, studies published, but there is still that unknown link of whether one works better than the other. And I'm sure, you know, Georgine has probably seen very similar studies as well. So does that help, Sylvia?
It does. It does. I know that is a topic that rears its head periodically, and we'll probably hear more. But I think it's important to know for our listeners that, you know, you wouldn't think it, right? But this stuff is important. These materials that are used have barriers. They're all different types of gowns. There are different types of gloves. There are so many things that go into our PPE for our healthcare workers. You know, and then there's, as we've seen through the pandemic, the FDA and CDC and other groups allowing for extended use because of shortages and supply issues. You know, APIC did just, you ladies are probably aware that APIC published its survey on PPE shortages during COVID. It was just released in early December. So folks, you can get that at apic.org. But talking about how so many different facilities during the COVID-19 pandemic were operating with shortages and needing to reuse or have extended use. So Georgine, just for folks who may not be in healthcare, can you help people understand the difference?
Well, when we think about the PPE, healthcare professionals are used to just using it one time and tossing it, disposing it after use. So, with the shortages that we've seen nationally, we've been, had to chase the guidelines on CDC and other guidelines, but they actually created some reasonable standards that we could employ at our hospital to do our best to keep our healthcare workers safe. And the same with the long-term care facilities. I know that we've all had trouble acquiring PPE. So it might be with the extended mask use, it may be something like you can use that mask, leave it on between patients. That's something that we don't typically do in non-crisis times. The same thing with reusing an N95 respirator, taking that off, saving it. Or sometimes we've actually, our organization uses Xanax, and I know there's lots of guidance where you can disinfect those and reuse the N95s. And then we've got the surgical face masks, or the simple face mask, maybe level 1, where we're wearing those in between and saving the resources for the bedside staff to use right when they're doing that direct patient care with a higher risk patient.
Yeah, I mean, it's sort of been a bit of the Wild West during the pandemic, but again, there are also some really creative new technologies that I think are on their way to help all of you stay safe, keep the patient safe. Georgine, I'm going to ask you if you had sort of, I don't know, one message you wanted to share with your healthcare colleagues, just if what would you want them to know about PPE?
Well, I think just even the public is that we really have to understand that the manufacturing of it and supply shortages are there, but infection preventionists are dedicated to their safety, and so when we advise things, we really are. It's based on evidence and research. We're following the most latest guidelines, and we're there to help them stay safe. And so it's a little bit frustrating when we see that. PPE fatigue, or staff wearing, say, their eye protection on their head and forgetting to put it on. So my other message, and I do say this frequently at our hospital, is to coach each other, stop each other before we go in the room and do it just in time. Oh, put your glasses down, your goggles down. So just a lot of support. Use the PPE. It's there to keep you safe, can prevent you from getting sick and then from actually taking an infection to another patient. So,
all right. So you guys heard that. Georgine is saying, don't give her a hard time. Wear your stuff. We know it's not always comfortable, not always fun, but so critical. What about you, Darlene? I mean, what would you want to say to your colleagues about PPE? And even now that much of the public has been exposed to this whole concept, given the history of the COVID-19 pandemic, what would you say? Here's your chance.
Right. Thank you for that, Sylvia. So, I really think it's important regarding the PPE. And if I give one message to healthcare workers or, within the health system, is to really listen to your infection preventionist. And the reason I say that is, and you'd mentioned it before, there's all kind of things coming out, different types of PPE, manufacturing, guidelines. And so in times of influx, whether it's pandemic or any other type of influx of disease, we, there are challenges there. But the infection preventionist is poised better than anyone, I believe, to take that information to be able to best utilize it in the world that they live in every day to keep our staff and patients safe and visitors that may come into the healthcare facilities. So that would be my takeaway, Sylvia, is, again, the infection preventionists are so well poised to take all that information and to utilize it in the best manner for the staff. So that's what I would say for PPE, is to listen to your IP.
Well, amen to that. I would also add that APIC as an organization is a place where healthcare workers may want to take a look at some of the The research, Georgine is among folks who've published in our American Journal of Infection Control. We have a lot of great resources. And again, even during the pandemic, one of APIC's biggest advocacy pushes was to ensure the proper supply of PPE. And so all of that information is available. And we agree, no one better than the infection preventionist to help anybody, really, mostly healthcare workers, but honestly, whether you're home health, long-term care, outpatient, that's the person you want to connect with. So with that, I want to thank Darlene Carey and Georgine Kruedelbach for sharing their wisdom, their time with us today. We thank you for being on the show. And with that, again, check out www.apic.org for more information.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff, including Silvia Quevedo and the APIC Communications Committee, in partnership with Human Factor. Audio tech is Blake Alphen.